Our group decided to focus on a therapeutic implant for ACL repair and regeneration. Our group identified a massive need for a new system of ACL repair and regeneration. Current repair surgeries are among the most common sports medicine procedures, totaling about 100 to 200,000 each year. The ACL is attached to the femur and tibia, providing a major chunk of the structural support in the knee, as it provides about 85% of the total restraining force of the anterior movement and prevents excessive tibial rotation, as well as guiding instantaneous center rotation in the knee, which gives it major control of joint kinematics. With all of its major functions comes some major downsides, because unlike other ligaments, when the ACL is injured, it is inhibited in healing itself as a result of it being surrounded by synovial fluid in the knee. The current solution to ACL tears is a total reconstruction with an autograft from either the hamstring or patella tendon. This procedure is done arthroscopically, and the damaged ACL is removed first. Drill holes are made in the tibia and femur to create future anchors for the new ACL, and the grafted ligament is then pulled through the holes and secured into place. This process has several disadvantages, such as longer surgical time, increased post-operative pain, donor side morbidity, as well as a higher risk and rate of failure as the graft may not take. Even successful surgeries have been giving patients unsatisfactory results, and these current methods of ACL reconstruction are not completely effective for returning those injured to their normal activities, and often leaves them at risk for developing osteoarthritis. It has been found that their expectation about their recovery has far exceeded the reality of their situations. Research has shown that biologically enhancing the repair can lead to a higher success rate with ACL reconstructive surgery. And new techniques such as bioscaffolds, use of platelets, platelet-rich plasma, and the use of stem cells are all techniques under evaluation. The use of these techniques can help mimic the natural environment for a regenerative ligament and can increase the success of ACL reconstructive surgery.
So in our design approach, we wanted to be sure to address the following areas. First, the scaffold must be strong in tensile and in bending, as well as hold similar elastic properties to the original ligament. It must also be bioactive and be non-tumorigenic. And in terms of biofunctionality, it must be able to survive in a synovial fluid environment and induce a fibrin clot. Our solution for obtaining a blood supply for our scaffold is by subcutaneously implanting it into the base of the patellar tendon for approximately 2 weeks before moving it to the torn ACL area. So after that 2-week period, this is what our solution will look like in reference to the knee. The dual material sandwich style scaffold is composed of 2 layers of collagen sponge, which are embedded with stem cells and platelets, with a structural silk backbone in between those 2 layers. The scaffold as a whole will be bioactively coated to promote stem cell proliferation and healing, and will be sutured to the torn ACL ends.
The risk of current grafting methods used for ACL reconstructive surgery can be resolved with the bioscaffold, which does not present the risk of donor site morbidity. The fabrication process can replicate the environment in vivo to increase the success of the reconstruction. Currently, there are more than 100,000 ACL reconstruction surgeries performed each year. Each costs between $20,000 to $50,000. About 1 to 8% of those require a second surgery, and of those 2,000 to 8,000, about 14% require a third surgery. In 2020, the average cost for ACL surgery was $14,000 for the surgery alone, which does not account for the cost of the graft used, hospital fees, and the post-operative doctor's visits. But health insurance can reduce the cost to the range of $5,000 to $3,000. However, if the patient chooses rehabilitation instead of surgery, the cost is around $88,000. Annually, the cost of ACL surgery is about $7.6 billion versus $17.7 billion for non-surgical rehabilitation. The cost of ACL surgery versus rehabilitation, in addition to no risk of donor site morbidity and the increased success of the bioscaffold integration, can greatly reduce the strain on those who suffer from ACL injuries both financially and physically.
We've discussed the different options for ACL surgeries, but this image offers a visual for the type of reconstructions available. The first image shows an ACL ligament that is torn. The second image shows a conventional ACL reconstruction with a replaced ligament. The third shows a bioenhanced ACL reconstruction that includes aspects of our design, but still requires a complete removal of the ligament. And then lastly, the bioenhanced ACL repair that our design falls under. The most similar competitor currently being looked into is the bridge-enhanced ACL repair clinical trial. A spud injected with patient blood is stitched into the torn ACL tissue to stimulate healing. The implant is absorbed over time and is replaced with new tissue. As of now, there has been a small 100-person 2-year study on this repair technique, and it has shown similar results to the standard ACL repair. Comparing the three techniques, ACL reconstruction is the market standard and is the only proven reliable method, but uses a patient graft and is not a bioscaffold. The new Bear technique uses a degradable scaffold to stimulate self-healing, but does not have a long-term study. Our scaffold idea takes from both of these methods because it has the added strength of the scaffold, similar to ACL reconstruction, and it uses a consistent blood source to help with self-repair, like the Bear scaffold. We believe this method will decrease the rate of failure in ACL repair and increase patients' ability to return to their prior level of movement and activity. Thank you.